afternoon, everyone. This is the FQHC Department of Human Services training session. This is Jill Vavakis. I am the Chief of Staff for the Office of Long-Term Living. And with me, we have Sherry Reinhart, Cindy Chris, Virginia Brown, Dr. Larry Appel, and Pam Bailey from the Bureau of Program Integrity. Mira Perez will be joining us in a little bit. I'd like to just take a moment to thank everyone for their interest and their ability to join us today. You should be seeing the agenda up on your screen. So as you can see, following our introduction, we'll be having a overview of the Community Health Choices program and have an overview of the waiver eligibility and physician certification process. Mira Perez will be here. She's just joined us. She'll be available for questions regarding the payment process. Pam Bailey will do an overview of program integrity, including the home health care and physician certification relationship to program integrity regulations. So at this time, I'd like to hand it over to Sherry to give a little overview before we get started.
I just want to echo Jill's thank you for your interest and for joining the webinar today. I think most of you know that Community Health Choices has already rolled out beginning in January of 2018 in the Southwest Zone. And will be, the rollout has begun for Southeast and shortly thereafter for the rest of the state. Just a heads up to everyone, I know many of you, when you hear CHC, think Community Health Center. So folks are going to try to say Community Health Choices instead of CHC. But if they say CHC for today, it is Community Health Choices, not Community Health Centers. Cindy and I will be taking minutes. There will also be a recording of the webinar available afterwards if you need to re-reference it. And after the session, if you have additional questions, you can feel free to follow up with PAC by sending an email to pachc@pachc.org. Thank you.
Okay, so this is Jill Vavakis. As you can see, there's a bar on the right-hand side of your screen. You can type questions in here at any time, and we can address the questions as we go through the presentations as well as at the end. So I just wanted to point out to everyone that you will also be given copies of the presentations for your future reference, and we will get started. Okay, so what is Community Health Choices, CHC? Community Health Choices is our managed care program that includes physical health benefits as long as long-term services and supports. We are being watched nationally because we are rolling out a managed care program for long-term services and supports, and we are one of many states that has done so. Each one of the individuals that's eligible for Community Health Choices are individuals that are 21 years of age and older and eligible for Medicare and Medicaid or dually eligible participants. Also eligible are folks that are 21 years of age and older and receiving some sort of long-term services and supports, whether that is happening in a nursing facility or happening in a home and community-based setting. We do have individuals that are currently enrolled in the LIFE program. If participants are folks are familiar with the LIFE program, The LIFE program individuals will not be enrolled in CHC unless they choose to be. And those folks that are eligible for CHC, if they're eligible for the LIFE program, they could choose LIFE as an alternative to Community Health Choices. Folks that are not part of CHC, Community Health Choices, are people that are receiving long-term services and supports through our OBRA waiver and not nursing facility clinically eligible. So the purposes of moving forward, nursing facility clinically eligible, we refer to as NFCE, and participants that are nursing facility ineligible, we refer to as NFI. So folks that are NFI, receiving services through our OBRA waiver, are not part of the transition to Community Health Choices. Also, folks that are currently being served through our Office of Developmental Programs, or ODP. We are a family of acronyms around here. Those folks are still going to receive their services through the Office of Developmental Programs and will not be transitioned into Community Health Choices. Also, residents in state-operated nursing facilities or veterans-operated homes will not be transitioned to Community Health Choices. So here's our population as a whole. I can tell you the numbers have gone up a little bit, but probably a few thousand at this point. Statewide, there will be 420,000 participants that will be transitioned into Community Health Choices program. 94% of these participants are dual eligible. So I refer to them as our bring your own PCP group. So Medicare is primary, and they more than likely have a Medicare PCP. Therefore, they will be using Community Health Choices for cost sharing and coverage of Medicaid covered services, non-Medicare covered services. So very key, and I'm going to say this many, many times throughout the presentation, Community Health Choices does not change Medicare. It does not change the Medicare coverage at all. And also to note, a participant, if they have a Medicare PCP, does not have to change their Medicare PCP. They can keep their PCP as they move into Community Health Choices. Something also interesting about this population, we have over 64% of the population are what we call healthy duals. So these participants are not receiving waiver types of services, or they are not nursing facility clinically eligible. Across the state, we have approximately 20% of our NFCE population, long-term services and supports population, that are receiving services currently in a nursing facility, and 16% are receiving that in a home and community-based setting. So you'll see as we move into the other overview of the next zone that we're rolling into, some differences up here across the zone. So here's our Southeast population. Sherry had indicated that we are rolling into the Southeast now. So we did successfully implement our Southwest implementation January 1 of 2018. We transitioned approximately 79,000 participants, and we are now full-blown into implementation of the Southeast zone of the state. This will include, this number's up a couple thousand, so this is approximately 129,000 participants that will be transitioning in the Southeast portion of the state. This group, specifically in the Southeast, we have a little bit lower percentage of dual eligibles, which means we have participants that are not dual eligibles but receiving home and community-based services or services in a nursing facility. So you can see the change in this population. We have more participants, 33%, that are receiving their services in a home and community-based setting, and only 11% receiving those services in nursing facilities. The percentage also is a little bit lower for our dual eligible or our healthy dual population. They're at 56%. Something I also want to point out for this population specifically in the Southeast, as we're moving into this zone, we realize that there's a greater number of these dual eligibles are receiving their services through a fee-for-service Medicare model instead of a managed care Medicare model. So they don't have a MedAdvantage plan or a MedAdvantage D-SNP plan like we saw in the Southwest. We only have 38% fee-for-service Medicare in the Southwest. So it's something interesting that we're seeing in the Southeast, that over half of our dual eligibles are still using a traditional fee-for-service Medicare model. And for us as the department and you as providers, that's important so that people understand that they're using a managed care model. They may need more assistance or information about understanding how the program might work. So here's our breakdown in the Southeast by county. You can see the lion's share is Philadelphia County, with Montgomery and Delaware, then following Bucks and Chester. So how does Community Health Choices work? I think that the majority of the folks on the phone are familiar with the seasoned Health Choices program. That's the managed care program that just includes the physical health benefits. So a reminder, Community Health Choices includes physical health benefits and long-term services and supports benefits for those people who are clinically eligible. So this program works the same way. Participants have to choose their managed care organization. And when they do make their choice, they need to consider the provider networks and any additional services that we may call value-add services by those managed care organizations that may be more meaningful to them. Some may have additional vision or dental benefits. Some may offer additional transportation or transition services, nursing home transition services. So each one of those value-add services may have a different value to different individuals. The Department of Human Services then pays a per member per month rate, also called a capitated rate, to the managed care organizations. And of course, we, just as the Health Choices program, have a robust monitoring structure to hold the MCOs accountable for our quality outcomes and efficiency and effectiveness. If anyone is interested, the Community Health Choices agreement is on our website so that you can see what the requirements are for each one of our managed care organizations. And then, of course, the MCO is tasked with and obligated by our agreement to coordinate and manage physical health services, long-term services, and supports for participants, and work with Medicare and behavioral health MCOs to ensure that they are appropriately coordinating care, as well as developing a robust network of providers, and I will touch on some of that network adequacy in a little bit. So the goals of our Community Health Choices program are to enhance opportunities for community-based living. If someone wants to live in the community, they can live in the community, and it's our responsibility to try and ensure that they receive the services that they need to be able to safely live in a community-based setting. So that's goal number one for us. Goal number two, strengthen coordination for LTSS services, long-term services and supports, and other types of healthcare. So that includes collaboration with Medicare and Medicaid services for dual eligibles, but also for the non-duals, it means coordinating with behavioral health services as well and community-based partners. So we are the program that is all about collaboration, and we have to be. We have 94% of our population that are dual eligibles, and Medicare is primary. So to enable us and the MCOs to ensure that we're appropriately managing the care for this population, we need to collaborate. We need to make sure that we're working with community partners, with our Medicare cohorts, our behavioral health partners, and our providers to make sure that participants are receiving the appropriate level of care and appropriate for that individual. Each one of our managed care organizations under Community Health Choices is required to have a companion D-SNP. So a D-SNP is a Med Advantage plan, so that's a Medicare line of business that is a special needs plan specifically for dual eligibles. So they are required to have a companion D-SNP. A member does not have to choose that companion D-SNP. They don't have to change their Medicare plan at all if they don't want to. They can keep their fee-for-service Medicare. It doesn't change their Medicare at all. But if they do choose to choose a Medicare line of business that's a companion D-SNP, then our managed care organizations in the Community Health Choices program are better equipped to coordinate care. But they are still required to communicate with our dual eligible plans, our non-companion D-SNPs. And we, the State Office of Long-Term Living in Department of Human Services, are also tasked with oversight of what we call the MIFA agreement. And the MIFA agreement is an agreement that we have with all 10 of our D-SNP, Medicare, Med Advantage special needs plans in the state of Pennsylvania. And we've enhanced the language in that agreement to require them to exchange data and information with our health plans, with our Community Health Choices health plans in the event that a member does not have a companion D-SNP. So their MIFA agreements have been enhanced, and our Community Health Choices agreement has been enhanced to require that everybody play nicely and exchange information for the betterment of our participants. Goal 3 is enhanced quality and accountability. So we started off the ground running with a robust quality plan. We actually gleaned so much knowledge and experience from our Health Choices program. It is, Health Choices has taken decades to season and grow into what they are today with value-based purchasing agreements and enhanced quality measures and requirements. So Community Health Choices benefited from that, and we've taken a lot of knowledge from our Health Choices partners and established quality measures at the beginning. So we have performance improvement plan requirements, we have hefty quality measures, and we do adhere to the HEDIS quality standards. There are quite a few measures that already started with the program, and we're making sure that we developed oversight at the beginning. So we could do subsequent sessions for folks if there's interest about our measures, and so that providers will understand what we're tasking of the MCOs, because that's always helpful, to know why a managed care organization is measuring you in a certain way. Well, it's probably because we're requiring that of them. So that's something that we could do in the future for you. Advanced program innovation, goal number 4. As part of our Health Choices agreement, or Community Health Choices agreement, we require the managed care organizations to use innovative ways to meet the needs of our participants. There are social determinants of health that a managed care organization needs to tap into community resources to try and meet the needs of our participants. And that means we do require that a managed care organization has a housing coordinator. They also must work with participants and their participant service coordinators to ensure that there's employment opportunities if they wish to work, enhance employment training for the individuals. So that means tapping into community resources for items that may not be a covered benefit. We also, finally, our goal 5 is increasing efficiency and effectiveness. And if we've done the first 4 well, then we know we're going to be seeing efficiency and effectiveness throughout the program. In order to measure that, we do have a lot of reporting mechanisms in place. We have operations reports, quality utilization and management reports, and launch indicators that we use at the beginning of each zone implementation to make sure that we're closely monitoring efficiency and effectiveness. So a comparison of fee-for-service and managed care. Of course, on the fee-for-service side, providers need to enroll in Medicaid as Medicaid providers. In the managed care side, that is also true, but I do want to point out that as a Medicare PCP that would be submitting for cost sharing to a managed care organization, they do not need to be part of that CHC network to receive payment for cost sharing up to the fee schedule, and I do have that detailed in the slide later on because I know that there'll be interest in that. Providers contract with the Commonwealth on the fee-for-service side. Yes, we still do revalidation. We enroll you, we do the revalidation. But on the managed care side, the managed care organizations are tasked with doing a credentialing process, and they follow NCQA guidelines for credentialing of providers. Part of that credentialing process is that they must have a medical assistance ID. So you start with us, and then the MCOs can credential you as one of their network providers. On the fee-for-service side, of course, providers bill the promise system. And on the managed care side, the providers bill the managed care organizations, and each one of the managed care organizations has their own unique claims processing system. So covered services, this is a big one because we've had lots of communication breakdown with the Southwest about providers thinking that Community Health Choices was just for long-term services and supports, or Community Health Choices was a Medicare product. No, that in fact that is not true. So think of Health Choices plus. So we are physical health services plus long-term services and supports for folks that are nursing facility clinically eligible. We also coordinate those behavioral health services that are covered by the CHC or the behavioral health managed care organizations. So all participants have the adult benefit package that's the same package as they receive today. That includes the physical health services of physician services, specialist services, and again, Medicare coverage does not change. All participants will have behavioral health services. Those behavioral health services are provided through the behavioral health managed care organizations. Those behavioral health managed care organizations are the same as they are statewide. They are by county. So they're the same behavioral health organizations that you've been working with already. This is new for some of our participants. So some of our participants that were in the aging waiver and folks that were residing in the nursing facility were receiving services, behavioral health services, through the fee-for-service delivery system. Once they get converted into Community Health Choices, they'll be receiving services through the behavioral health managed care program, MCOs, and they will receive additional benefits that they did not receive in the past. So on this slide, you will see some of the services that are available to them. And I do know that there's been a lot of outreach, and specifically in the Southeast, the counties have been getting involved in targeting education to nursing facilities and participants that are eligible for services through the behavioral health managed care organization, so that they know what services will be available to them and how to access them. So transportation services, all CHC participants, Community Health Choices participants, have access to emergency and non-emergency medical transportation. So just as through the Health Choices program, participants will continue to use the Medical Assistance Transportation Program, MATP, for non-emergency medical transportation to and from medical appointments. Participants residing in nursing facilities are the exception in that nursing facilities have traditionally in the past arranged for that transportation. They can still do that. Each one of the managed care organizations has a transportation broker. So providers can work with that transportation broker to arrange for transportation. They will work with nursing facilities to help coordinate transportation as needed. An additional benefit for this population, nursing facility clinically eligible participants, those folks that are eligible for the waiver types of services, also have access to non-medical transportation. So non-medical transportation includes transportation to, church, if they want to go to community activities, if they need transportation to employment or volunteer activities. This transportation benefit must be part of the person-centered service plan for that individual. They will work with their service coordinator to ensure that transportation services are included in their service plan. And it could include tickets or tokens for public transportation as well. That service is not a replacement for medical transportation, and it's not, it's only offered as an additional benefit for those participants that are nursing facility clinically eligible, and it's part of their service plan. So participants that qualify for long-term services and support, nursing facility clinically eligible participants, they can receive home and community-based services and supports that include personal assistance services, so services in the home to help with, bathing, dressing, light housekeeping, those types of services. Home modifications, vehicle modifications, personal response services, and a new benefit under Community Health Choices is pest eradication. We're very happy to include this service. It was communicated as a huge need, and it is a social determinant of health. So if, in fact, you do become aware of a participant that is in need of pest eradication services, please bring that to the attention of the managed care organization. They do have folks at the plan that are responsible for helping to coordinate those types of services for our long-term services and supports eligible participants. And if they're in a rental, that means that that's where that housing coordinator comes in again to make sure that those services can be coordinated with the landlord or whatever is needed for those remediation services. Folks that are in a nursing facility, the long-term services and supports in a nursing facility would be under this bucket of covered services. And participant-directed services. So participants that are the common law employer, they're employing their own direct care worker, that falls under this bucket of covered services. And those services will continue today. The only difference under the Community Health Choices program is that the managed care organizations are coordinating the payroll to go to the financial management services vendor to pay the direct care workers. So continuity of care. For physical health services, it's 60 days, just as it is for the Health Choices program. But as we transition into Community Health Choices, we do have an extended continuity of care period of 180 days following a zone implementation for all long-term services and supports. So that means that managed care organizations are required to contract with all willing and qualified existing long-term services and supports Medicaid providers for 180 days after CHC implementation. That means participants can keep their providers, their long-term services and supports providers for a 180-day continuity of care period after that zone implementation. Nursing facility residents can stay where they are as long as they need that level of care unless they choose to move. And the Commonwealth, we DHS, are closely monitoring the MCO network adequacy to make sure that they have provider networks that enable choice for our participants for any needed services. So identifying the needs. I think under the Health Choices program, Physical Health Choices program, folks are familiar with the case management areas of the managed care organizations. That's for your chronic disease and behavioral health or cognitive requirements. Under CHC, as soon as implementation under the Community Health Choices program, a managed care organization is required to screen each new participant that are healthy duals within 90 days of the start date. That's a huge lift. They have to contact every member that starts with their plan within the first 90 days to make sure that there's no gaps in care and needs are appropriately screened, to make sure that they aren't missing necessary services or need to have a needs assessment. They must conduct a comprehensive needs assessment for every participant who's already nursing facility clinically eligible. And they have to conduct a comprehensive needs assessment for certain types of trigger events where the participant self-identifies the need. The CHC MCO themselves have identified a gap in care or a need, or the independent enrollment broker identifies that the participant has unmet needs or needs service coordination of some type. Also, they have to conduct an assessment if a trigger event occurs. So if they have an inpatient stay, the MCO must conduct an assessment at that time. After that, they must conduct a reassessment of at least every 12 months, unless a trigger event or one other of those events do occur. So the MCOs under the Community Health Choices program are not only responsible for the care management plan, so that's your chronic disease, cognitive and behavioral health needs, but also a person-centered service plan. So all of our long-term services and sports participants will have a person-centered service plan, and that plan includes both the care management and the long-term services plan. Person-centered service plan is developed through a planning team process, which includes the participant and any informal or formal supports that the participant wishes to include. Could include family members, their provider, their PCP, their service coordinator. The service coordinator is the hub of that person-centered planning process. So coordination with Medicare, I did touch on this before. It's essential that we coordinate with Medicare under this program. And again, Community Health Choices does not change Medicare, does not change the Medicare benefits. The participant does not have to change their Medicare plan if they do not choose to. But this program does promote coordination between Medicare and Medicaid, and it is focused on patient outcomes. So our dual eligible participants can continue to receive Medicare options as they do today. They could maintain having original fee-for-service model Medicare. They could choose a Medicare Advantage plan. They could choose one of the D-SNP plans. And that the CHC implementation does not change any of the services that are covered by Medicare. I did already share that each one of the MCOs are required to have a dual eligible special needs plan. And Medicare will still continue to be the primary payer for any service covered by Medicare. Providers continue to bill their Medicare of the participant for eligible services prior to billing Medicaid. And all Medicaid bills for participants should be submitted to the participant's Community Health Choices MCO, including bills that are submitted after Medicare has denied or paid part of the claim. So keep in mind that participants must have access to the Medicare services from a Medicare provider of his or her choice, and the CHC MCO is responsible to pay the Medicare coinsurance and deductible amount up to the fee schedule, whether or not that Medicare provider is included in the Community Health Choices Managed Care network. So I'm going to stop 1 second. We did receive a question. What happens if MATP transportation will not transport the patient because the specialist they need to see is in the next county? If this is a Medicaid covered service and it is a Medicaid provider, then the MAT transportation should assist with a cross-county transportation. You should follow up with that participant's managed care organization to work with the MATP provider. There's also MATP transportation contacts. Those are all the same. We also have an organization within the Office of Medical Assistance Program that has oversight for the MATP program, and that information is out on our website with the contacts from DHS who have oversight for that particular county. So if you want to send me the particulars for that individual and the situation, I can get that to the appropriate people for you to resolve the issue. Okay. Service coordination objectives. So if folks are familiar with service coordination is a service that's for our participants that are long-term services and supports, nursing facility, clinically eligible. Now folks that are in the nursing facility under Community Health Choices will also have a service coordinator. But service coordination, traditionally in our fee-for-service model, service coordinators were an enrolled provider. Service coordination now is becoming an administrative function of the managed care organization, just like care and case management. Every participant receiving long-term services and supports will choose a service coordinator. That service coordinator is responsible for coordinating across Medicare, long-term services and supports, physical health services, and behavioral health services. They are also the hub for accessing and locating community resources for covered or non-covered services, so social, housing, educational, and other support services and support. Each one of the service coordinators does facilitate that person-centered planning team. They are an administrative entity of the managed care organization, and the managed care organizations could be using service coordinator entities that are separate and apart entities that they've subcontracted with, or a participant could choose a service coordinator that's actually an employee of the managed care organization. Each of the participants does have that person-centered planning team, and it includes folks such as their doctors, service providers, and any natural support. So provider payments. How are providers paid and the provider rates paid? And I know that Mara is going to touch specifically for your group about the FQHC payment methodology. But you will note that the same requirements for FQHCs under the Health Choices program are the same for the Community Health Choices program. So the Community Health Choices MCOs are paid a per member per month capitation rate, and those rates were developed using historical fee-for-service data, and of course they were adjusted for the additional benefits that an MCO may be providing, as well as projections for growth, adjustment for managed care principles, and improvements of care coordination. Our 2019 rates have already been developed, and there was consideration taken with the fact that there will be an extended continuity of care period. Following the continuity of care period, the Community Health Choices MCOs will negotiate reimbursement rates with providers. So just like as in the Health Choices program, DHS does not get involved in that negotiation of rates between a provider and the MCO. However, we do have contractual requirements regarding, the contents of a provider agreement, and the notification of changes in network and that type of thing. The CHC MCOs can also negotiate with providers to perform specialized services. And the Community Health Choices MCOs may have regional rate variations. And again, DHS does not get involved in negotiations. Now, if you have attempted to resolve any types of billing or issues with the managed care organization and you do not see that you're having any success with that, you can come back through the FQHC Association, and Sherry will make sure that we get that information and work with you and the managed care organization to try and resolve any issues that you may have. So I think we touched on how the rates your provider rates are determined. And again, we, MCOs and DHS, have agreed upon tools for high risk or high cost participants. So after January 1, 2019 in the Southeast, participants served under the Community Health Choices program, services would be billed to that managed care organization. Each one of the MCOs does have their own claims processing system, and the managed care organizations are required to go through training. So you are required to be trained. The MCOs are required to have a training plan. They are also required to allow you to have a testing period. So if you have not worked with managed care organizations in the Southeast, please do so. And if you haven't, please let Sherry know, and Sherry will work with us to make sure that we get the managed care organizations working with you to get that testing set up. I do also want to point out, although the electronic visit verification, or EVV, does not apply to FQHCs, there is a requirement for home health services that the department is working on through a federal requirement. So those types of arrangements are also being still developed based on those requirements from the federal government. That won't impact the FQHC billing process. And also, if you have not had an opportunity to have any type of contact with the managed care organization, like I said, we'll make sure that we can get that started and up and running for you.
Are you mentioning later who the managed care organizations are?
I am.
Okay.
There's a slide with the contact information for them, and I'll leave it on there for a little. I also want to take the opportunity at this time to mention that if you have any questions, you can always send them to my attention as well, and at the end I'll give you my email address. So providers have the opportunity to participate in claims testing. Like I said, our managed care organizations are required to adjudicate 90% of clean claims within 30 days and 100% within 45 days. So that's a federal requirement. We monitor that very closely. The CHC MCOs do determine the payment cycles, and we will monitor their monthly processing files to make sure that they are in compliance with those claims processing standards. We do assess sanctions and impose sanctions on the MCOs if they fail to make timely payment to providers. So Southwest implementation. I touched on this a little bit. We effectively transitioned 79,000 participants January 1, 2018 in the Southwest. We are now up to 81,000 participants in the Southwest with the growth. We had lots of lessons learned in the Southwest. So big one was do everything sooner. Absolutely everything sooner and more frequent. We needed to engage our stakeholders much sooner, and we did that with the Southeast. Enhanced communication materials and training regarding Medicare versus CHC. So we also worked with the Pennsylvania Medical Society and CMS because we had a lot of confusion for our Medicare docs who, remember, 94% of this population has a Medicare doc, and they didn't understand what Community Health Choices was. We also have a group of people that are currently being served under Health Choices that are transitioned to Community Health Choices. So in the Southwest, we had approximately 8,000 people that were going from a Health Choices plan to choose a Community Health Choices plan. And they're not the same plans. So that caused some confusion, and it did cause some confusion with docs. So I'll touch on that a little bit once we get to the MCO slide. But in the Southeast, we have 14,000 people that will be having to choose a Community Health Choices plan. So this go round, we enhanced our communication, and our Health Choices plans are going to be sending out a letter in the next 2 weeks to those participants that are transitioning to let them know. And we, the department, have actually drafted this letter. And that copy of that letter will be out on our website, as with all of our other materials. So we worked with CMS to develop a Q&A document that went out through the Pennsylvania Medical Society newsletter to touch on some commonly asked questions for physicians. And we enhanced our communication about the continuity of care period. We asked our managed care organizations to start provider training and outreach earlier and more often, especially the service coordinators. We did earlier OBRA reassessment. So everyone in the OBRA waiver, we did a reassessment to ensure that they weren't NSCE and eligible for Community Health Choices, and we are done for the Southeast. We had stragglers last year. We're focusing on doing earlier data cleanup in the HCSIS and SAM systems. So HCSIS and SAMs are two case management systems. One is for under 60 population, one's for our over 60 population. And the problem in the Southwest was that we didn't really effectively focus on cleaning up both systems, and they house case management notes. So we passed incomplete and inaccurate data over to our MCOs to set up the care plans. So for the first 2 months of our implementation in the Southwest, we had to work with the managed care organizations, work with service coordinators to fill the gaps in that data. So we're doing a much better job of right now of doing data cleanup to make sure that before we pass the information over to the managed care organizations that it's accurate and complete. We also did more earlier pre-transition notices to the participants. And any transportation issues, we've enhanced communication about transportation services. In some ways, for our long-term services and supports participants, they may have been receiving transportation services in a way that we really weren't aware. So we've actually learned more about how some transportation services were being provided to our long-term services and supports participants. And we have scheduled a transportation summit for transportation providers in the Southeast that will be occurring November 16th to make sure it's being hosted by SEPTA. So we're actually working with all of our transportation providers in the Southeast to make sure that we're all on the same page when we head into implementation. So here we are, Southeast. I did touch on how we're incorporating all of our lessons from the Southwest. We did enhance our participant communication. We've actually just completed conducting 72 outreach sessions for participants. We have received requests from some adult day centers and nursing facilities to come and do one dedicated sessions if they have Medicaid participants that will be transitioning to CHC. So we may be doing a few additional, but we did enhance all of our communication for the Southeast. The priorities for our implementation, of course, is no interruption in participant services, continue to provide those services, and no interruption in provider payment. We were very lucky, very fortunate with the Southwest that our provider community was very supportive during implementation. If they had any issues not being able to see authorizations and that kind of thing for the managed care organizations, they knew they were under that continuity of care period. They continued to provide those services. So we didn't have those interruptions of services while they were able to work out any payment or authorization issues with the managed care organizations. So we were very fortunate to have that collaboration and participation from our provider community. We, the department, of course, we have a rigorous readiness review process. We have, once we move into our implementation, we will have daily war room meetings every morning with each individual meetings with each MCO. We also have end the day with a daily meeting of all internal DHS staff to make sure that everybody's on the same page of any issues that we might be seeing. We're collecting weekly launch indicator reports. So those are reports about complaints, denials, claims processing, paid, denied, pending claims, any changes in service plans. And we are having weekly stakeholder meetings. So we have individual meetings with stakeholder groups, home health providers, nursing facility providers, AAA service coordinators, our consumer advocacy groups. We are still continuing to have them weekly, and we will be doing that continually through Southeast implementation. And the importance of that is this is a partnership. We work very closely with our stakeholders and providers. You're our boots on the ground, and you can tell us if there are individual cases that need our attention or any items that aren't going smoothly. We're also working very closely with the Department of Health to review and approve the MCO's networks. So they have oversight of ensuring that the MCOs are meeting the network adequacy required for their operating authority. So of course we have our readiness review process. We're checking all materials. I think we're about 90+% done with reviewing all policies and procedures at this point in time for the managed care organizations for the Southeast, so we're ahead. We have regular ongoing stakeholder communication that I'll touch on in a little bit, and Of course, we have a lot of coordination between our offices and enhanced training that we have built over the last year that's all on our website. So for network adequacy for the physical health side mirrors what's on the Health Choices side. On a national level, any instances where a participant goes to the provider, it's based off of driving times for urban or rural settings. That is the same for community health choices. When it comes to long-term services and supports, there were no national network adequacy standards, even though many states have implemented an MLTSS program. Those states have had network adequacy of a choice of 2 providers for participants. We in Pennsylvania were not happy with that, and we worked with our consumer advocacy groups and Department of Health to establish our own network adequacy standard for long-term services and supports. So this is for instances where the provider goes to the participant, to their home. And we based that off of past claims utilization and translated that into full-time equivalents. So when the managed care organizations are entering into network adequacy agreements or network agreements with providers, they're asking them how many employees they have serving the community, and that's because of us. So we did have providers say, wait a minute, why are you asking this? Well, asking for this is, we've never been asked this before. Well, that's why. The department is now measuring network adequacy of the MCOs by their ability to meet these full-time equivalents needed to meet the needs of our participants based off of our past utilization. And we will be refreshing that on the go forward with the encounter data that we receive from our managed care organizations. So now we have states asking us how we're doing it, and we'll be happy to report on how that's going as we move forward. So here's our map. Phase 1 was Southwest, Phase 2 Southeast, and Phase 3 is going to be a bear for us. It's approximately 215,000 participants for Phase 3. It includes 3 zones: Northwest, Northeast, and Lehigh Cap, and we will be doing that in 3 waves, but during the 1-year time period. So we're implementing Phase 3 January 1, 2020. Here's your managed care organizations. AmeriHealth Caritas, Keystone First. So AmeriHealth Caritas is in the Southwest, and they operate as Keystone First in the Southeast. PA Health and Wellness, they are new to Pennsylvania. They are part of the Centene Corporation. And UPMC Community Health Choices. So those are our 3 managed care organizations. They will be serving all 5 zones. They are our Community Health Choices plans. So back to those participants that are transitioning from Health Choices. In the Southeast, we do know that out of those 14,000 people that are participating with Health Choices, about half of them are with Keystone First. They can stay. They can choose Keystone First, or they can choose another of one of the other 2. We also do have a large percentage that are Health Partners participants. So that's the reason why we decided, okay, we want to send out some dedicated notices, have the Health Choices plan send out notices so that they understand that they'll have to make a new choice. I think it's about 5,000 that are Health Partners. About 1,300 are United, and about 460 are Aetna for the Southeast. So we are doing not only our regular outreach, but some dedicated outreach to this communication, to this group of people. Okay, so communications. This is so exciting. We have the best website ever. We've done a lot of work on this website. I'm really proud of this because I did come from the HealthChoices side, and I know that, the program was pretty seasoned, and we didn't have all of these materials. We are setting the bar because we have loads of materials, and for the Southeast and the Phase 3, they really lucked out because they're going to benefit from all the communications that we've put together. So there's two sides to the website. There's the provider resources side, so that's for providers, and then there's I need or receive services for participants. And this is the provider side, so there's a question and answer document. So last year we entitled this Frequently Asked Questions, and it has over 800 questions, so we decided to take the frequently off because you can't have 800 frequently asked questions, but we did add a nice table of contents so you can search by subject matter. These are not one sentence responses either. They are comprehensive answers. So I do encourage people to check out that if you get questions. Then subscribe to CHC News. This is a listserv. So this is an email blast. So if you want news about Community Health Choices, just go to that link and put your email address in, and then you'll be added to our communications list. Presentations, all of the presentations, including variations of this one, are out on our website. This is exciting. So these are our narrated training segments. It even gives you a time commitment. So if you're like me, you like that audio and visual. It even has fact checkers built in. And I've had some providers tell me that they used this during their employee meeting, and played it, and they watched it together. So I encourage you to check them all out. But the overview is 30 minutes long. Guess what? You can't fast forward. I'm sorry, but we did that on purpose. Direct service providers, so that would be your physical health providers. That would be a good one for this group. Service coordinators and nursing facilities, so folks that are in nursing facilities and nursing facilities social workers, that would be a good one for them. This is the fact sheet, so we're putting out new fact sheets all the time. We just sent one. It's a 17-page fact sheet, so it's fact sheets, but it's on EVS, so the eligibility verification system that I know everyone so finally uses every time somebody presents for a service to check their eligibility. We actually did a 17-page fact sheet to let you know whether they will be eligible for CHC and whether they're eligible for waiver services. And it tells you what it looks like if they've moved from Community Health Choices to, or from fee-for-service to Community Health Choices. It also gives you a copy of the ID cards. So you'll know what the ID cards look like for the 3 MCOs. So if a participant chooses Keystone First for both their Med Advantage and their Medicare plan, they will have one card and both information will be on one card. If they choose 2 different ones, then there's a copy of what that single card will look like for Medicaid. So this is what they look like. They're really nicely done. We have a nice young man in our secretary's office that is really good with graphics. So all of these are posted out on the website so you can use them to educate participants as well. Now this is what the participant side looks like. And this is where you find all of the documents that participants receive. So you can have a copy of every single notice that we've sent out to participants. If they call you and they say, hey, I received this letter, you can go out and look and see what it looks like. So this is what we've done so far. We sent out awareness flyers in July to all of those 129,000 participants in the Southeast saying, this is what we've done, this is what's coming, and this is what you're going to have to do. And then we had Aging Well events. Aging Well is an organization that hosted those 72 participant sessions that just ended. They started in August and they ran through last week. And there was invitations that were sent out to participants about those sessions. Then the department sent out pre-transition notices to that group of participants saying, hey, you're going to be transitioned to Community Health Choices, and soon you're going to receive an enrollment packet. Then the enrollment packets started going out from the independent enrollment broker. So now those pre-transition notices are going in phases, so there'll be multiple notices, and the enrollment packets go out after each phase. So participants will be told that they have until November 13th to make an MCO selection. But if they don't, of course, one's going to be auto-assigned to them, but they have until December 21st to change. So in essence, they can choose a plan up till December 21st for it to become effective January 1. If they choose after or decide, oh, I don't want to be with that plan, I want a different plan, and they make the choice after December 21, then their choice will become effective February 1. So they'll have to be with that plan for the first month. Service coordinators and nursing facilities. We have done training for them. Service coordinators have been fully trained. There's been probably over 700 service coordinators have participated in the training and have done outreach to over 6,000 participants in the Southeast at this point, the meaningful contact and talking to them about community health choices. So between the registrants for the participant sessions and our service coordinator outreach to our long-term services and supports participants, we've touched over 10,000 participants at this point for the Southeast. Nursing facilities are also outreaching to their residents and letting them know how to make a choice. Our participants, they are being told that they need to make a choice. So if a participant asks, yep, you have to choose an MCO, one of those three. This is the enrollment broker website for Community Health Choices. We have Third Thursday webinars. So these are public webinars. The information is on our website. Anyone and everyone can call in to these Third Thursday webinars to learn more about Community Health Choices. We've also hosted guest speakers. So last time we had our traumatic brain injury providers talk about how to do assessments for that type of groups of participants. You know, any interest for subjects that you would like to see, please feel free to send that to us, and we'll be glad to include that in our Third Thursday webinars. We have stakeholder engagements. We have public meetings. We're continually doing outreach such as this one, so any ideas, additional sessions you would like to see, please let us know. Again, you know, talk to your MCOs about contracting and developing those provider agreements. Participate in our sessions and our Third Thursday webinars. You know, read and share within your organization. Any information that we receive, we will share additional updates through Sherry if you have interest about a particular area. Any of those additional educational sessions that you want to see us do, we can gladly do that for you. Here's our resource information. So, the listserv information, you go to this website and sign up for the listserv. There again is our website. We have many public meetings that are subcommittees of the MAC meeting. We have a Managed Care Long-Term Services and Support sub-MAC. That's open to anyone, and they are public meetings, and we have past information and materials out on our website. They are transcribed, so you'll be able to read that as well. Any additional questions you can send to our RA email box. We've also listed our OLTL provider line and participant line, and the independent enrollment broker. So if folks need to make a choice of their managed care organization, they should make the choice through the independent enrollment broker. The phone number and website is there. So with that, we did
really a marathon.
Yeah, we did receive another question, so we'll wait for Mara to go over that question. So I'm going to turn it over to Virginia Brown and Dr. Larry Appel to talk to you about our waiver eligibility process and the physician certification process.
And do I just use the button here?
Yep.
This one here?
Yeah. Okay. Back and forth, yeah.
Okay, great. Thank you, Jill. As she said, this is Virginia Brown. I'm the Policy Director with the Office of Long-Term Living, and with me I have Dr. Larry Appel. He is our Medical Director. And this sort of came to light. This has been a process that has been the process forever for determining eligibility for our home and community-based waiver programs. But just within the last several months, we received an inquiry from the Delaware Valley Health Center in Philadelphia asking about the physician certification process and really expressing some concerns that they had with regard to some of the behavior of our providers in the Southeast. So we made a trip down to Philadelphia and provided them with some information. And Dr. Appel and I felt that it was very, very useful for us in terms of the questions that people were asking. So I think that was part of the impetus behind scheduling today's call. So with that, I'm going to just, I know Jill has talked about long-term services and supports and has referenced our home and community-based waiver programs. But essentially, the Social Security Act allows, gives states statutory authority for providing services to individuals in their homes and communities if they otherwise would be eligible or qualify for Medicaid-funded institutional care. And so when we talk about Medicaid-funded institutional care, for OLTL primarily, that's services or care that individuals would receive in nursing facilities. Outside of Community Health Choices, OLTL manages 4 home and community-based waivers which serve 4 very discrete target populations. So they are the aging waiver, the attendant care waiver, the independence waiver, and the OBRA waiver. And you may have also heard of the ComCare waiver, which served individuals with traumatic brain injuries. But for the rollout of Community Health Choices, we needed to use the ComCare waiver to become our Community Health Choices waiver. So individuals that were being served in the ComCare waiver were transitioned to the independence waiver, where they're receiving the same services that they were receiving in ComCare. So with our move to managed care, these 4 waivers will be consolidated into one new waiver called the Community Health Choices waiver. So what that means is individuals in the Philadelphia area who are currently receiving services, for example, through the aging waiver, will transition to the Community Health Choices waiver effective January 1st. Again, what this means for many of our participants is they will have the opportunity to receive many new services that they weren't able to receive in their current respective waiver. For example, the attendant care waiver is a very small waiver in terms of the package of services. It primarily offers personal assistant services or attendant care services and a personal emergency response system to individuals along with their service coordination. Those individuals, now that they're transitioning to Community Health Choices, will have a broad array of services that are available to them. And some of those services are adult day services, home health services, which include nursing, OT, PT, speech and language services. Jill talked about home and vehicle adaptations. So there are also services to support employment for individuals who wish to work. So it's really a much more robust package of services in Community Health Choices. So with regard to eligibility, there's really what I call the three stools, or the three legs of the stool. It's not three stools, three legs of the stools of eligibility. So there's the clinical eligibility. So the individual must meet the specified level of care. And for OLTL, as I said, all but one of our waivers requires an individual to be nursing facility clinically eligible. And that eligibility, that clinical eligibility, must be redetermined annually. So initially, the individual has an assessment that's done by our local area agency on aging, and the individual also needs to get a physician certification from their primary care physician. Those two pieces help determine level of care. When the redetermination is done annually, the only piece that's necessary is the assessment piece. The physician certification is not required annually. The second leg of the stool is financial eligibility. So the individual must be eligible with regard to income. Their income may not exceed 300% of the federal poverty guidelines. And in 2018, that was 2,250 individuals for $2,250 for one individual. And then also they must have assets or resources that are less than $2,000 with what's called a $6,000 disregard. So it's essentially they can have $8,000 in assets and resources. And then the third piece of eligibility is, does the individual fit the target group of the waiver? So when I talked about our current waiver programs, they all have specific target groups. So the aging waiver serves individuals aged 60 and older. The attendant care waiver serves individuals with significant physical disabilities that are expected to last indefinitely, and those individuals must be mentally alert and able to direct their own services. The independence waiver also serves individuals with significant disabilities that are expected to last indefinitely, and those individuals must have 3 or more functional limitations in life activities. And then our OBRA waiver serves individuals with physical developmental disabilities. So those are individuals that their disability occurred before the age of 22. So they may be individuals with cerebral palsy, individuals with spina bifida, muscular dystrophy, those types of developmental disabilities. So in CHC, we've really broadened, again, our target group. It's really what we're really focusing on, and the group that we're wanting to serve in our home and community-based waiver in CHC is individuals that do have physical disabilities that are expected to last indefinitely. So that's not someone who, for example, broke their leg and they're going to be, they're going to be laid up for 6 weeks, or an individual who has broken their hip, needs to go to a nursing home for some rehabilitation, and then they're going to be fine in their home. It's really individuals that have long-term ongoing disabling conditions. So with that, I'm going to turn it over to Dr. Appel so he can really talk about the nursing facility clinical eligibility requirement and the physician certification form.
Thanks so much, Virginia, and thanks, Jill. My name is Dr. Larry Appel, and I am the medical director for the Office of Long-Term Living. I wanted to take just a few moments and speak about the physician's role in determining eligibility. The physician's role, as Virginia mentioned, there are three legs that determine eligibility. There's a clinical leg, a financial leg, and a program leg. And the physician's role is primarily concerned with the clinical leg. Nursing facility clinical eligibility is defined in the following way. One, the individual has an illness, injury, disability, or medical condition diagnosed by a physician, and as a result of that diagnosed illness, injury, disability, or medical condition, the individual requires care and services above the level of room and board. And the individual is certified by a physician that the individual is nursing facility clinically eligible. Now, the needed care and services are either skilled nursing or rehab services as specified by the Medicare program, or health-related care and services that may not be as inherently complex as skilled nursing or rehab services, but which are needed and provided on a regular basis in the context of a planned health program of healthcare and management that were previously available only through institutional facilities. Now, what we're speaking of here, primarily clinically, when a physician is presented with this, is there are really four main factors to consider. Physicians should consider mobility, cognition, toileting, and eating. And these factors often should be considered in combination and not just separately and independently. Sure, that's mobility, cognition, toileting, and eating, and really all aspects of those four. So when a physician is presented with a physician certification form, what they really need to do is consider the four factors just outlined and ask themselves, does the participant meet the definition above, especially in relation to those four factors? And one part of that to be highlighted is Part B under Section 4. Do they have health-related care and services that require, needed and provided on a regular basis in the context of a planned program of health care that were previously only available in the nursing facilities or a facility? And this makes for often the home and community-based services waiver participants. Now, the physician certification form that many physicians have seen several times, I just wanted to point out a few features. Number one, there is a physical diagnosis requested on that form, and so the more diagnoses, the better in terms of outlining this form. It also asks for ICD-10 codes to back up the diagnoses, which is a very helpful thing as well. The length of care required is also requested, and the physician is asked to choose either long-term or short-term. Now, short-term is up to 180 days. So as Virginia was mentioning, while we are not looking for somebody who is going to just go to a nursing facility for a short period of time, 180 days, there are several consumers that will be short-term, but they will be up to 180 days. So it is up to 6 months, or long-term, which certainly the large majority of consumers fulfilling eligibility will fit into that category. And then the level of care. So there's nursing facility clinical eligibility. There's intermediate care facility for persons with other related conditions, and we'll talk about that in a second, or none of the above. So those are the three choices that a physician has regarding the physician certification form. And when Virginia and I were at the Delaware Valley Community Health Center, the physicians were telling us that they were receiving many of these forms. And so what we're asking physicians to do is go back to the definition just talked about, and again, consider the four factors and an overall condition assessment of the patient, and decide which of the following terms and also levels are required. Now, a couple of features of the form to point out. Number one, The form must be signed by a physician, MD or DO, and they need to include their license letter number on the form. So this does not include mid-levels. The physician needs to sign the form. And the form needs to be returned to the IEB as soon as possible to avoid any delays in this overall process. Second, this intermediate care facility for persons with other related conditions. Virginia did mention the definition here, but it's worth going over again because I've seen several of these forms and it's somewhat confusing. The ICF-ORC is in no way to be considered a middle ground between nursing facility clinical eligibility and other. Excuse me. Can you read? It results in substantial functional limitations, inability for self-care, mobility, self-direction, and independent living. It requires an active treatment program that tries to focus as much as it can for clients to achieve as much self-directed or independent living and decision-making as possible. So again, just trying to avoid some confusion about this checking the box of intermediate care facility for other related conditions.
Just a question going back to what Jill said earlier about they can't fast forward on something. Is it possible to do just the physician certification piece for the providers so that health centers and others would have that so that the providers could quickly go through that piece of the education?
I could certainly do another video or webinar, and we can certainly talk, and we'd be happy to do our piece about this.
Because I would not want them to have to go through everything with a provider that is already challenged with time.
Absolutely, and that certainly makes sense, and our experience at Delaware Valley and other experiences with federally qualified health centers would lend itself to doing that as well, so we'd be happy to.
Wonderful.
Okay. I actually am going to turn it back over to Virginia to describe the ongoing services and how the physician certification form fits into the eligibility process.
Okay. So what I'm going to do right now is really walk you through what the eligibility process looks like. So we have an entity called an independent enrollment broker that really helps facilitate the process for the individual. So the individual who's looking for long-term services and supports should contact the independent enrollment broker. The independent enrollment broker will then make the referral to the local area agency on aging for the clinical assessment and will assist the participant or facilitate the obtaining of the physician certification form. Some individuals like to take the form directly to their physician. Other individuals have the IEB send the physician certification form to their physician. But it's just important to note that this is an important part. There's two pieces to determining clinical eligibility. So you're an important part of that clinical determination. So once the physician certification form is completed, it needs to be returned to the IEB, and that's either the participant can return it to the IEB or the physician can return it to the IEB. And then the IEB will also work with the individual to facilitate the financial eligibility process at the local county assistance office. So the county assistance office will determine whether the individual is financially eligible for Medicaid and primarily for long-term care services funded through Medicaid. That's a bit more complicated than just finding someone eligible for what I call vanilla Medicaid, which is essentially our SNAP benefits, LIHEAP benefits, and our Medicaid health choices or health benefits. So once eligibility has been established, so the individual has been identified as being clinically eligible, they are financially eligible, and they meet one of the target groups, the individual will choose a service coordinator who will work with that individual to develop an individualized service plan and choose providers to deliver the services. And Jill talked about the comprehensive needs assessment. The service coordinator is responsible for conducting that needs assessment with the individual, and that needs assessment really looks at a whole host of issues for the individual and really talks with the individual about what their goals are. And that's what helps drive the individualized service plan. Does the individual wish to go back to work? Does the individual need supervision during the day, but rather than having someone come to their home, they would rather go to an adult day program? So it really tries to look at the individual holistically to identify what services and what preferences the individual has for meeting their needs, and then choosing providers to deliver the services. And I think the reason why we are focusing on this is some of the concerns that we heard from Delaware Valley Health Center was that they were receiving these physician certification forms from providers and or from family members who were saying, I need you to fill out this form so that I can get a job and work for my mother, for example. That is, while we do allow our participants to hire family members to be their caregivers, the intent of this program is not to be an employment program for family members. So it's really, I think that's part of the message that we want to get across, is that the forms should be coming to you either from the individual or their representative or the IEB. You need to be looking at it with regard to clinical eligibility for the individual. And then the service provider shouldn't be telling you how many hours of service the individual needs on their service plan. That's really a conversation between the service coordinator and the individual based on that needs assessment.
And one other piece of this is that if you're presented with a form, and the folks at Delaware Valley expressed this, that sometimes they were very uncomfortable because they were presented with forms and felt under pressure to sign the form or indicate nursing facility clinical eligibility when they did not think that nursing facility clinical eligibility was met as per the definition, once they understood the definition. And if that situation occurs, then you should feel very empowered to know, and we'll talk a little more about this, that you are not under any obligation to sign that form, and that it is entirely appropriate, and you are being asked to specifically and only use your clinical judgment related to the factors involved in the definition. And the pressuring events should not be taken into account.
And one other thing I'd like to just bring up around the clinical eligibility piece. So we, as you know, we have the two pieces. We have the physician certification form, and we have the clinical assessment that's done by the local area agency on aging. There are times when the physician feels one thing and the local area agency on aging feels another. When there are discrepancies between those two pieces of information, they come to the Office of Long-Term Living, and our medical director and other medical directors within the Commonwealth review the information, and may actually reach out to the physician to have a conversation to make that final determination on eligibility.
Absolutely.
So once the individual gets into service, I'm just going to talk a little bit about the ongoing services that an individual receives. So as I said, the individualized service plan is developed with the participant by the service coordinator based on a comprehensive assessment. That assessment is done annually, or when a participant's needs change, or if there's a trigger event. And those trigger events are things such as the individual has a hospitalization, or something significant has happened in their household. For example, their spouse may have been providing a lot of informal support to them, and their spouse has now passed away or had a health event that prevents them from assisting that participant. So the assessment's done annually with the participant by the MCO service coordinator, or outside of managed care by the service coordinator. The participant is responsible, or works with the service coordinator to choose the providers to deliver the services that they need on their service plan. And the service coordinator is responsible for notifying the selected providers of the amount of service, the duration, the frequency, the type of service that's needed for that participant. Physicians are not required to prescribe services, with the exception of home health services, which are nursing services, PT, OT, speech and language therapy, nutritional consultation services, some specialized medical equipment and supplies, and assistive technology. So again, just to emphasize, you should not be getting a phone call from a home care agency asking you to prescribe 10 additional hours of service for an individual. We do not require physicians to prescribe services. And then, as I said already, if the participant's needs change, the service coordinator will conduct another needs assessment to identify any additional unmet needs and make necessary revisions to the service plan to meet those needs. I think that's it for us. So we'd be happy to take any questions that people have. I don't know that we've gotten any.
No, we're fine answering.
Okay, great.
Great.
So Jill, I guess we'll turn this back. We're turning this down to Mara, right?
Yep, I believe we
Okay, so I'm the speaker that everyone is waiting for. I don't have a presentation.
Oh, okay.
As we go along, we are in a different room from where our printer is, so if you want to submit questions, I have 3 here. I will talk briefly about what the requirements are, and a lot of them are similar. So all of you are participating in our Health Choices program today, so everything is similar. I will tell you all that we are managing the PPS side for Community Health Choices. We will work similar to how we do on the behavioral health side through the Office of Long-Term Living when we identify non-compliance or potential non-compliance between the plans and the health centers. So it's a little bit disjointed on how we contact the plans, but we will be getting all the information directly from the FQHCs. So for the 2018 implementation, some of those of you out there, everybody's at a different level on the number of patients that you see that are dually eligible, and that is our big population that we get questions on pretty frequently. If you have already been in contact with my staff, we have been doing some ad hoc reporting from the Southwest health centers related to CHC. We are planning to formalize and issue out a wraparound report for CHC with the next packet of wraparounds, which include your MEI increase. I would say that timing is set for late December, similar to the usual release of templates, and will include a CHC template. One notable difference in the CHC template is we've added a line for the Medicare revenue reporting. So similar to all of our other managed care operated plans, CHC is requiring the PPS rate be paid. And this is because a lot of the members that are, almost all the members that are going in were covered previously by fee-for-service. And in fee-for-service, you were able to bill Medicare first and submit for PPS rate to Promise. So we're making that transition similarly in CHC. So all of the CHC plans are required to pay the PPS rate set by, your PPS rate set by the department. We do issue them a report that shows what the PPS rates are currently. And we do, for those of you that have a change in scope, we do issue them notification on any retroactive change in PPS rate. So for those of you participating in the Southwest Zone, they would be required to cover any PPS rate change back to January 1, 2018. For those of you that are looking to participate in the Southeast Zone, that will be any change back to January 1, 2019. So I'm going to pause in case you're pondering and you want to submit questions.
Should they also be providing any change to the MCO?
Yes, we always request that you submit your letters to the MCOs. So we do have two sister MCOs. They are actually the same MCO, but we do not necessarily work with the same individuals between HealthChoices and Community HealthChoices at the plans. I'm not sure how it works because I know that you all work with your provider representation. We work with the financial staff. So we do request that you submit to your provider rep for Community HealthChoices your rate letters as well when you have a change in rate. We also communicate that to the financial staff, and both UPMC and AmeriHealth do also participate in our HealthChoices program. So there are similar people working on the effort, but not the same people. So if there are issues, you should let us know. Is the issue CHC or is it HealthChoices or both? So for reporting on the dually eligibles, you would submit your invoice, your billing to Medicare. Medicare will make payment. In submitting billing to the CHC MCOs, I know I used the acronym, but that's, if you email me, that's what we would see. The CHC MCO, you would submit the T1015 billing code. So for those of you that heard me speak at the annual conference, please do not submit for a PPS encounter any other code. When you do that, we're not able to provide help to you on the back end because we also get encounter data. Yes, the Community HealthChoices MCOs do submit encounter data to the department, and we utilize that to also do assurances to make sure that they're paying appropriately. So if they're giving you direction otherwise, please let myself, let Lori know that you're being given different direction. But you should be billing for a PPS encounter T1015, T1015U9, and if you're doing any other services that will require a modifier, so remember behavioral health, HealthChoices pays on the other behavioral health modifiers. There can be some modifiers other places, but it should be T1015, T1015U9 for CHC. Again, I'm going to pause in case you're pondering and want to submit questions. So you would then submit, along with your billing, your Medicare explanation of benefits that shows what Medicare has paid. So that the Community HealthChoices MCO is similar to the other MCOs, able to reduce their payment by the following. They can reduce the PPS payment by the revenue you receive from Medicare, and if the individual has an MA copayment, that MA copayment is then reduced. So we do get questions today in Promise on why the PPS rate is additionally reduced. For dually eligibles, some of them do have copayments. So in this population, you have to factor in both the MA required copayment, and I think we have a max of like $6 in MA for copayment, and the Medicare revenue.
Can you say that one more time?
Yes. So for this population, most of them do have a copayment obligation under MA. So your payment that you should receive would be the PPS rate less the Medicare revenue, less the applicable MA copayment. And that MA copayment is required for the patient to pay at the time of service. Okay, again, I'm just giving some pause to, we are getting questions coming in the door, so so when you're submitting wraparounds to us, we are including fields for you to be able to record all of the revenue. But again, the key piece here is make sure you're billing T1015. If you're being instructed to bill other codes, you need to let us know, because we're not able later to look into the data and make some validation on where you paid appropriately if you do not bill T1015. Okay, so I'm going to go through a couple of questions that I received. I have quite a pile. Are MCOs, CHC MCOs required to pay the Medicaid PPS rate minus the primary Medicare payment, or do they only cover the cost sharing or Medicare copayment? So I think I already answered that. You do also need to factor in the MA, the medical assistance copayment that's required. Will we still be able to bill for primary care for duals that are required to choose one of the 3 plans? If so, is this temporary, or will we be able to continue that indefinitely? So you should bill Medicare for the services that you're providing and any other third-party liability that would exist for that patient initially prior to billing medical assistance. And that's regardless of any plan that they choose out of the 3 plans. You would be required to bill Medicare first, or any other third-party liability. Is there any anticipation that the FQHCs will be required to contract with all 3 entities? So the Community Health Choices agreement language requires the MCOs to have a provider contract with all FQHCs in the zone in which they operate, so they're all 3 operating in the Southeast zone, that will accept the PPS rate. So as I told you about Health Choices when we came up, you should be expecting those contracts or any changes to your provider contracts to clearly state that they're required to pay your PPS rate for the services that are eligible under the PPS policy. So anything that's eligible to generate T1015 should be paying PPS, and I would expect that they would clearly document that in your provider agreement. So I think, I'm looking at Jill, I think we're expecting that you would be approached by all 3 plans.
Yes.
You don't have to have a contract with all 3 plans if you as the FQHC choose not to. If you choose not to and you're having an issue with getting a contract with one of the plans, you should let Jill know so that we can have a conversation with that plan, because they should be paying your PPS rate. So if there's a disconnect on what their understanding is and what they're telling you, we want to make sure that we have that discussion with them.
I think the other point, if I'm correct, the provision in the physical health choices that even if you're seeing a non-attributed patient,
I don't know that off the top of my head. I will need to talk to Jill. We added language about the patients not allowing denials for patients based on PCP, but I'm not sure exactly what's in theirs completely. If they mirrored ours, yeah, we'll have to follow up with that.
I think it is.
I think they have exactly the same language, but it's been a little while since I looked at her contract.
Yeah. While we're going, I'll look it up. But if it's in, it only applies if you have a contract with that CHC MCO. So it would be another reason to consider contracting with all.
Yes, if you don't have a contract, if you have a dually eligible patient, you are seeing them for Medicare, and you do not have a contract with their CHC MCO, we will require you to seek out-of-network payment with that MCO. So that is a recent answer that we've given on the Health Choices side. So you would have to contact that Community Health Choices MCO to get their requirements for their out-of-network payment. We do not necessarily know that for emergent services. There is a requirement on the payment level.
Yeah, they have to pay it.
They have to pay the fee-for-service amount, which is your PPS rate.
Right.
But for non-emergent services, it would be their policy. So I would encourage that if you're having difficulty getting a contract with one of the MCOs, that you let Jill know or let me know, so we can have a conversation with that MCO. We would like to see contracts with all the FQHCs in the Southeast Zone and with all 3 of the managed care plans. Okay, and I do appreciate that everyone is thinking about what we're talking about and sending in questions. There was earlier talk of capitation contracts for the CHC plans. Will this be the same expectation for FQHC contracts, given that we receive PPS per encounter? So I think what you heard, and I think what you're thinking about here, and you can maybe send in more detail, is around value-based purchasing. So health centers do a lot of services outside of the face-to-face encounters for PPS. It's really between you and the managed care plan to negotiate what additional services you would be willing to do. I know that for some of you that are doing the COE program, this population may also be seeking treatment under your COE. So there are different things that you're doing for the population in general. So you should be having that conversation with the managed care plan if there are things that you are doing for your Health Choices patients that you think might be beneficial for this population that's really outside of the face-to-face encounters.
And that doesn't go on the wrap.
That is correct. So anything that's done that's billed not as a T1015, and there's a lot of other things going on between managed care plans and the FQHCs, especially as on the Health Choices side, we've moved into a lot of value-based purchasing arrangements. Everything that's not billed a T1015 is not counted in the wrap and is not paid at PPS rate. It's paid at whatever your rate is that you've negotiated with that managed care plan. So I know for some of you that are running patient-centered medical homes, there's some PM amounts that you're getting to cover individuals that are attributed to you as a patient-centered medical home. That's something that's outside of the face-to-face encounters that may, if that's your arrangement with the managed care plan, be capitated. It's not counted. That revenue doesn't offset your encounters. So again, I'm going to pause. So those of you, if I didn't get your question exactly right, if you want to follow up with some additional thoughts, I'd be happy to answer more there. We understand that we should submit the T1015 code. Is it okay to include the specific CPT codes if requested by the payer, or should we only submit T1015? So a lot of the payers require additional coding because of HEDIS measures, and as Jill spoke about earlier, we do take quality very seriously. We do utilize HEDIS as our measurement tool. So a lot of the payers do require additional CPT codes. Some of them require that you bill 0 on T1015 and bill amounts on the CPT code, that you bill all your payment on the T1015 and bill some nominal amount on the CPT codes. That doesn't matter. You should bill T1015 in there. The mix of additional services is based on what you've agreed to with that managed care plan, and it's really needed for HEDIS purposes, and they should only be paying on T1015. So a lot of times we see that they pay 0 on the CPT codes and still pay your PPS rate on T1015. If a patient is dually eligible, Medicaid copayment is still collectible at the time of service. That is correct all the time. However, there are rules around what is required if they're unable to pay. So you should, if you have a specific question on that, you can send that in to my group and we will respond directly and maybe give guidance to the association. But if they assert that they're unable to pay their copayment at the time of service, there are rules around that.
Yeah, if you can provide that we can send it to everyone.
After we receive a Medicare payment and we bill the Medicaid HMO using the T1015, do we bill our full PPS rate or the PPS rate less the Medicare payment amount? you always bill your full PPS rate. And they're required to pay the current PPS rate regardless of what's billed. Now, often that gets us into trouble because we have lots of back and forth where funny things go on. We always ask that you bill your full PPS rate. Regardless of what they tell you, if your PPS rate is $100, bill $100. So we have a law, we can move on, and as I get more questions in, we can circle back to me at the end. Thank you, everyone.
Okay, so now we're going to move on to Pam Maley from Bureau of Program Integrity. Your left
Okay, good afternoon, everyone, and thank you, Jill, for inviting me to speak about program integrity. I've been talking quite a lot to a number of different groups and committees and associations, so I'm always glad to share about program integrity. I'm a registered nurse. I have been in this position since 2002, but I've worked in the Bureau since 1992. So I have a lot of experience here and a lot of experienced staff underneath me. So today I'm going to give you just a very quick overview of who BPI is, and that's Bureau of Program Integrity. We are under the Office of Administration and have 3 different divisions there. Talk a little bit about some really very pertinent rules and regulations. Go through our review process so you understand what we do with our provider and recipient and caregiver reviews, some of the administrative actions we can take, some federal audits that are occurring that you as providers may be contacted, and I want you to be aware of what that means and the participation that's expected from that point, and then end with some tips and references. And again, please feel free to submit any questions as I go along. So the Bureau of Program Integrity is really an enforcement agency, and like I said, we impose administrative sanctions. We are in the Code of Federal Regulations, federally mandated to have an agency to prevent, identify, and combat fraud, waste, and abuse within the Medicaid program. We monitor the provider's compliance with Medicaid rules and regulations, and we want to ensure that our recipients are receiving quality, medically necessary services and that they're not abusing their benefits. I have about 34 registered nurses that report to 4 supervisors underneath me. Our total BPI staff is about 75 staff within 2 divisions. And then we have a 3rd division that's third-party liability, and that's another 3-hour discussion. So tend to just, put them aside. But for the program integrity staff, we do have board-certified physicians on staff that can also assist with the reviews. They're looking at quality of care, medical necessity, and health and safety issues that the nurses would forward to them. We have internal medicine, emergency room, physiatrist for rehab services, a surgeon, a dentist, a psychiatrist, and a pediatrician. So quite a varying group there. We also have pharmacists and certified professional coders, and some other areas there that are supportive and administrative assistance. I'm not going to read through these, but these are regulations or definitions that come from the federal regulations of fraud and abuse, and these are often confused. And I just want to point out that fraud is an intentional deception, that you're trying to get a benefit that you're not authorized to receive. And that benefit can be money, can be a service, whatever, but intent must be proved. And that's something that's frustrating for our office, that we get a number of allegations of fraud, but if we can't prove intent through our Attorney General's office, then it becomes a case of abuse and is an administrative sanction, not a conviction to pursue down that road with a criminal action. I listed some regulations here. The Code of Federal Regulations specifically has 2 parts that are related to program integrity and utilization control. I encourage you to read these if you have some time at some point. They're a little dry, but if you can look at those and appreciate that for everything that is outlined there, the state agency must have a policy process for that, and in an audit we have to show proof that we are following these. And that's really how I learned these so much in detail, by having an audit years ago that actually went sentence by sentence. Where's your policy? Show us how you're enforcing this. Also, the state regulations, Chapter 1101 is the general provisions. There's a lot of information there, and that does apply to all providers. And then, of course, you have your provider type specific regulations. The provider handbooks and billing instructions are always important and are updated periodically. There is a regulation that you have to bill according to the instructions that are contained therein. So I encourage you to educate your staff, that is your office managers and building managers, that they can keep up to speed with those instructions that are there. And then Jill has mentioned the HealthChoices, Community HealthChoices website, where there are agreements and various other information about the programs. These agreements do give our Bureau authority to review managed care network providers. These agreements also require that the managed care plans have their own special investigation type unit where they can conduct reviews of their network providers and monitor for any recipient abuse. I listed a couple bulletins here with the website that you can look at them for further information, but these are ones that I typically share because they're very important for most all providers, except for the second one. But it's things that you should be doing and monitoring within your program and ensuring that you're complying with what's stated in these bulletins. The first one is the enrollment of ordering, referring, and prescribing providers. This is a provision from the Affordable Care Act and was effective in April of 2016. So all your practitioners that are working in the federally qualified health centers, all your home health providers must ensure that all the practitioners are MA enrolled before they can go into a managed care plan or work for others. We have found problems with this in that in group settings, one person is billing for everyone within the group and maybe 4 other practitioners that are not Medicaid enrolled. So in that case, we look at that. That is a misrepresentation of the actual rendering provider. We recover the money for that, and consequently, the practitioners are then enrolling.
There is a caveat to this requirement under the Community HealthChoices program. Under the managed care final rule, under a managed care program, the provider does not have to be enrolled to order, refer, and prescribe. And the providers, the Medicare providers, in order to receive their cost sharing or Medicare covered services, do not have to be enrolled for the managed care plan to pay them that cost sharing.
Okay, right. Medicare does not have to be enrolled.
Right.
So your CHC's rule is different than HealthChoices rule?
No, HealthChoices, under the managed care program, under the managed care final rule, a provider that is not part of the managed care provider network does not have to be enrolled to order, refer, and prescribe. If they are part of the MCO's network, then they must be an enrolled provider.
Right.
If they're rendering, they need to be enrolled.
Right. So I miscommunicated that. Yes, I understand. Yes, I agree with what you're saying.
Yes.
Yeah.
So I just want to make sure that it's understood.
Yes.
if we get any follow-up questions, because I know that that's been a hot topic specifically under our program, because we have 94% that are dual eligibles, and they were concerned that they would have to switch their Medicare docs if they were not an MA enrolled provider.
Does not apply to Medicare.
Yes. If they are receiving services from a Medicare physician, and that physician then can bill the managed care organization for cost sharing up to the fee schedule, they do not have to be MA enrolled.
That would not apply for all of our
And they can prescribe services and not be enrolled. Right. And the managed care organization would be required to test. Right.
But they can't render the service, not be enrolled. It's refer, order, and prescribe. Right. Yeah. My example was rendering. They were rendering the service and were not MA enrolled and were billing under a primary physician who was enrolled.
Okay.
Yeah. So we're on. Okay. The face-to-face requirement was effective also in 2016. That the physician must prescribe home health DME supplies prior to the initial start of home health services, and they must be related to the primary reason that the recipient requires the home health service. This is a physician face-to-face encounter. However, it can be conducted by a non-physician practitioner, which they defined as a physician assistant, registered nurse practitioner, certified nurse midwife, and clinical nurse specialist. So the encounter can be performed by any of those above. However, the actual order has to be written by the physician. This is something that we're also monitoring within the department and can recover money if there is no documentation that the encounter was performed or that the physician actually ordered the service. This encounter must be done within 90 days prior or 30 days after the initiation of the home health services. The third bulletin is the implementation of criminal background checks. This is, again, an Affordable Care Act ruling, and this was effective in April of last year, that it assigned high-risk levels and is for newly enrolled DME, home health, and attendant care providers at the high-risk level. Upon revalidation, it can be lowered to a moderate risk level. And with this high-risk level, it involves fingerprint checking through the FBI and other background checks. And I just make you aware of this, that there is an additional level of scrutiny there with the new enrollment of those provider types. And then the fourth one is applicable for all providers to be screening their employees and contractors per the federal requirements. This was effective in August of 2011, and the screening should be done upon hiring and monthly thereafter. It involves checking state and federal databases, and if there are any catches, I'll call them, for someone who is listed on one of those databases and they're employed within your facility, that is something that should be reported to our Bureau immediately through a self-audit type process. And I share two examples with you that I did have a hospital that employed someone who was a nurse who had been precluded. So she was not practicing as a nurse. She was pushing the stretchers around. But she is still employed by a hospital that had a high Medicaid population. She did not self-disclose. And when they found it, once they started doing checks, they did report it to us, and we ended up recovering the cost of her salary and the cost of her benefits, even though she was not doing direct patient care. She was still excluded from participating directly or indirectly in any state or federal program and receiving any monies through that source. The other example happened actually in an FQHC, where there was a pharmacist who was terminated, convicted and terminated. He went to work for the FQHC and also did not disclose that he was a data entry clerk. Once the FQHC again started checking, and this was probably about 2 years ago, they self-disclosed to the federal OIG and to us, and had to again pay back his salary and the cost of his benefits for over a year's period.
Yeah. Because a couple of our health centers shared your term catches that they had and the penalties with years. We actually went through a due diligence process evaluating vendors that do this on a very methodical basis, and the board has recommended a provider of those services that many of our health centers are using.
Very good. Yeah, it's really for their protection too.
Right.
Okay, for the ordering practitioners, and this kind of goes off of what Virginia was talking about with, you know, when you're ordering things, you want to make sure that it's necessary, that you're not ordering something just because someone is encouraging you to sign this form and trying to talk you into ordering services that may not be necessary. And I just point these out so that you can be aware of regulatory compliance to ensure that you're following the regulations, but also that it would help with the home health providers or the waiver providers to ensure the recipients are receiving just what is medically necessary and appropriate services. So for the practitioners, you're required to adhere to licensing standards and basic standards of practice in the general regulations in providing any medical care and in ordering any services. Any treatment that you order, including drugs, is appropriate to the diagnosis. It must be based on the history and physical, and it is really vital that you document all of that. The medical necessity has to be documented, and the services, and this is one you can use, the services that you order cannot be in an amount that exceeds the recipient's needs or cannot be ordered solely for the recipient's convenience. There are also provider prohibited acts that can lead to really egregious practices and can end up in allegations of fraud that we would refer to the Medicaid fraud control section. And these are kind of the things that if you're ordering something that is not medically necessary and the waiver program is submitting claims for services, then you have to question, are they submitting a claim based on false information or a false order for something that is not medically necessary and does not benefit the recipient? It's really then false authorization for the service. And they should not be submitting any claims for services that are without a practitioner's order except in an extreme emergency. So the home health providers, they've been talked about already. I just want to point out with the home health agency, again, the home health services are recertified for every 60 days. This provider type must also be Medicare certified to be a participating Medicaid provider. It's been talked about with the waiver services, that is an authorization every year that they remain nursing facility eligible. And there's the two different models there, home modifications and the non-medical transportation that we review within our bureau. And then also the durable medical equipment and supplies. Many of those services are prior authorized, but there's also the requirement that there be a face-to-face encounter before those services are received. Now to go a little bit into some of our process, Our nurses act as case coordinators. They start a case and finish the case. They identify a case for review looking at our fraud and abuse detection system, which can profile and do peer comparisons and uses a lot of different algorithms to provide reports for us. We, of course, receive complaints and tips through our website. We have a MA provider compliance hotline, which calls are received there, and they can be anonymous. We receive calls from neighbors, providers, friends, family. I did say providers. Just a lot of different sources there. They come into that the one area and are triaged. Claims are pulled, and then the information is forwarded to the section supervisor for that provider type for review. We also receive a number of referrals. Our comptroller's office completes quarterly audits, and they're looking for edits that may not have been working or areas where a new edit may need to be put in place. We have our prior authorization area. Our policy area sends things to us when there are new program coverages and new codes that are going to be authorized so that we can review and monitor the billings on those subsequently. The MCOs are required by contract to advise us of their reviews and recoveries and to forward tips that they receive, because if it's one MCO may be seeing something, but what we can do in our bureau is look across all the MCOs to see the impact with that provider. And of course, law enforcement forwards things to us that they have deemed to be not criminal or not fraud in nature. So our review process begins with the claims review for the designated time period. We typically do targeted reviews through the processes that I just explained. We request and review the medical records, looking at the medical necessity, the appropriateness, the quality and quantity, and any other required documentation. We then have a two-step process to notify you, the providers, of any findings that we may have. We begin with a preliminary findings letter that includes the regulatory citations and the listing of claims that have been in violation. Upon receipt of this letter, there are options for the provider to submit additional information that may change our findings, and also to request a teleconference or a meeting if they wish to discuss the findings. There is also a contact person in this letter that you can call and ask any questions of. After any review, then we go to the second step where we're notifying the provider of the final findings. And with the final findings, there's the request for restitution, which can be done either through claim adjustments and voids or through payment by check. This letter also includes the right to appeal and gives you the instructions, and it asks for a corrective action plan. This is a written compliance tool that is used to hopefully improve processes and help you with your compliance plan to eliminate deficient processes in the future. Now, we have historically always been doing the retrospective fee-for-service reviews, but in the past couple of years, we have started doing managed care network provider reviews. With that, the process is just a little bit different. We receive a number of complaints and tips, again. We also look at items that we've looked at in the fee-for-service program to look at as a managed care program. We're reviewing the encounters for the designated time period. We do internal vetting to look for past history and is there any case with federal or state law enforcement. We also check for the licensing backgrounds and any disciplinary actions. And then we send a letter to the managed care plans asking them for vetting items that we ask for background complaints, any cases they may have done, and we ask them to send us their claims that have been paid to that provider. We then review the claims and compare them to the encounters. and then request medical and physical records from the provider and review those for the compliance with the regulations. And then, like I explained under the fee-for-service process, there is a two-step letter process. Again, we call them the preliminary findings and the final findings. The difference here is that instead of sending them to the provider, we send them to the managed care plan with just a copy to the provider. What we do is we follow the money. So the department is paying the managed care plan. The managed care plan is paying the provider. So our recovery and notification goes to the managed care plan. We will recover from the managed care plan. The managed care plan then has the option to send a letter to the provider and recover for the regulatory violations. The managed care plan can appeal to the department upon final findings. The provider can appeal to the managed care plan upon final findings. For the results of our review, we're really hoping to protect the participant in the delivery of the healthcare services, ensuring quality, medically necessary, and appropriate services. One task that we've taken on this year is validating that the medical services were rendered by licensed, certified, or trained individuals. We've developed a process to receive a report from the Department of State monthly for any license suspensions or terminations. We bounce that against our active provider list and can take action to terminate that provider agreement and recover any monies that have been paid for services after they have lost their license. We're also validating the medical services I mentioned before with the home health service agencies needing to have Medicare certification. So we have a quarterly report run that captures Department of Health information for any Medicare certification that has ended, and then we can match that again against our active providers. We do recover the Medicaid overpayment and are required to return the federal share of those dollars. And I mentioned the corrective action plans. So additional actions that we take, we may find an issue and send the provider a letter asking that you conduct a self-audit to see if you can identify additional claims that may be in violation. And in that case, there is no penalty when you do a self-audit. There is just a $1 refund for the restitution, but no additional penalty for doing that. We refer issues of health, safety, quality to the Office of Long-Term Living for all these home health and waiver services. We feel that's really important, and with their regional offices, they can refer it to the areas for further review to ensure that services are being provided, that no one's being left without the services that they need. We refer our federal cases of allegations of fraud to Medicaid Fraud Control Section, which is within the Office of the Attorney General. We also have federal agencies that are very interested in, right now, physician cases is big. And then Department of State licensing that we refer matters there for review. We can terminate a provider's agreement and preclude their participation in the managed care in the medical assistance program. This is for egregious violations, violations with the provider prohibited acts that I mentioned, fraud convictions, loss of licensure and certification, and also failure to pay restitution. I wanted to mention the recipient restriction program because this focuses on recipient abuse, and I think in the FQHCs you may see some of this, and I want you to be aware there is such a program and can report to us of anything that you may see. This is a process in where recipient claims are reviewed in both fee-for-service and managed care. We're looking for misuse and abuse or defrauding of the program. This is usually through what we quote as doctor shopping or frequent ERs, flyers. They're receiving excessive services. They're not medically necessary. They may be sharing their card. They may be forging and altering prescriptions. We are very interested in receiving that, and we do get a lot of referrals from pharmacists and physicians just of the prescription issue with forging and altering prescriptions. We do ask the physician to put in writing for us that he did not order this prescription, did not order this drug, did not order this quantity, has never been his patient. With that, we impose a restriction. What the restriction means is that in the promise payment system, and if applicable, it's the managed care payment system, their medical card is restricted to the use of one pharmacy, one physician, one hospital, if that's where the misuse has been, through the emergency room. So it helps control a little bit and provide some medical management to steer them towards one provider for the services that they're needed. It's not always the true all. They can go out and pay cash, we find, and you know, that's off of the car, not using their medical cards, so we can't control that. But the recipient restriction is in place for 5 years. It's something that is a federal requirement that we can do, and all states have that. And I encourage you to report. I have reporting places at the end of the presentation. If you feel that there's anyone that may benefit from having some medical management and some restriction, at least in the payment of the card, that directs them to one physician. Restrictions are not applicable in the case of emergency services, so that is a federal requirement, and we have to restrict them to someone of their choice. Okay, for the CMS contractor reviews, there's two that I wanted to make you aware of. The first one is PERM, and you can imagine some of the pictures we put up about that. Payment error rate measurement. This is a joint effort between the state and CMS. They calculate a Medicaid improper payment. They look at recipient and provider eligibility for the date of the service. They look to see, did the claim process correctly on that date of service? And from the provider, they ask for the record to document and support the service on that date. This review is done on a 3-year rotation. CMS does 17 states per year, and Pennsylvania is now. So the providers, or the contractor, will be requesting records from the providers shortly. And the CMS vendor that is doing this is called CNI Advantage. Connie Nancy Indian, CNI. Don't believe CNI stands for anything, but just if you receive a phone call or a letter from them, please cooperate and comply by sending in the record. They usually only do a few claims. They don't pick a provider and ask for 50 claims. It's really very random, and only a few records from a provider. If the record is not received by the CNI Advantage contractor, it is an error for our state. And we're very happy that we have been below the national rate of errors. In 2015, which was our last review, the national rate for Medicaid errors was 5.7%. Pennsylvania was 3.2%. The other contractor review is called the UPIC, Unified Program Integrity Initiative. This is a CMS awarding contracts to vendors that are working in 5 different zones. Pennsylvania is part of the Northeast zone, along with 10 other states. The contract was signed in March of 2017. And what the UPIC is doing is simply performing PI functions much like our Bureau does. They will do data analytics, they will review, conduct audits, they can do on-site visits, they will do medical record reviews, and come up and determine violations that then the state can recover for. They do go through a vetting process with the state, and they have approvals for any provider type that they are beginning to review. Right now, they are reviewing non-emergency medical transportation, durable medical equipment, and laboratories, including orders and then the subsequent claims that are submitted by the labs. Oh, and I did include a website there that there's additional information on our website if you'd like to read more about those two initiatives. So, some useful tips. You, the providers, can initiate self-audits. It's a voluntary review and disclosure of the overpayments that the department then validates, and again, there's no penalty as long as there is no fraudulent activity. We have what's called What's New on the DHS website. I encourage you to check this frequently. It includes new medical assistance bulletins, quick tips, and RA banners. We also have information about how to implement and monitor your corrective action plan on our website. And it seems every conference I go to, they talk about monitoring social media. Our recipients, participants, just put all kinds of things out there. They talk about sharing their cards. They talk about selling their DME supplies. It's selling their drugs. It's amazing. It's eye-opening. So I encourage you to have someone monitoring that also. Made a list here of where you can report fraud, waste, and abuse. The hotline comes directly into our office and is monitored by a person during the day. After that, messages can be left. We have the email, the fax, of course, mail, and there's a phone number to report any recipient abuse of medical services that you may find. I've included references, sites here for our DHS website. Jill went over the HealthChoices, Community HealthChoices website, which I agree was very easy to go through and a lot of great information there. And there's two websites listed for the Bureau of Program Integrity. The first one talks more about fraud and abuse. The second one talks more about our organization, the responsibilities of the 3 divisions, and our hotline. Listed there are contacts for the Bureau of Program Integrity. Karen Fickus is our Bureau Director. My name and phone number is there. I also included the 2 supervisors that report to me. Susan Troutman is a supervisor for the Home and Community-Based Services section, and Beverly Croft is the supervisor for all practitioner reviews and also for the recipient restriction program. And any questions? If we finish here, I guess they can come into
through
Sherry or Sherry, and okay, and be forwarded on to us. And I am known in the office for trivia or quotes or something like that. So my final slide is a thought for the day. And I did a conference recently in August in Texas, so I wanted to do Pennsylvania. So Pennsylvania has a Statue of Liberty out in the Susquehanna River. Pennsylvania has the Grand Canyon. Pennsylvania also has what is thought to be the first roller coaster. This was a mining car that was used, and the locals decided in the late 1800s they'd pay a nickel to be able to ride this and thought it was a lot of fun. So then my quote for the day, because you're at heights and everything, is when it all seems like an uphill struggle, just visualize the view from the top.
Okay. All right.
Escape again. There we go.
So we'll just give it a minute for any additional questions. If you don't get your questions submitted today, you think about additional questions that you might have, please go to Sherry and Cheryl, and we will be glad to get any additional information back to you. And with that, do you want to close out with anything, Sherry?
Just thank you again, and we appreciate the partnership with all of you. You've been very responsive as issues have arisen in the Southwest. We very much appreciate that.
Great. Well, thank you so much. And again, We look forward to implementation in the Southeast. All right, good afternoon, everyone.